bigger institutions don't have that same mindset. They don't really care about the community or the individuals per se. They care about what the numbers look like. And unfortunately, we are in that cross current in the state of Connecticut currently. We have two very big systems which are doing very good job, very good work, but so are we at ECHO. We don't back off from anybody. We put in all the robustness of clinical trials and research in our community. We know what our limitations are. I would not do some tertiary surgery at Bacchus Hospital where my practice is. I would not do some crazy phase 1 clinical trial in my office yet. And I'm saying yet, because we will. And why do we think we will? Because we strongly believe cancer care is local. It should remain local. Probably 15 years ago, 80% of cancer care was given in the communities. Now it's down to 60-65% because of all the network integration and practices being swallowed by one organization or the other. In fact, this past Monday, one of the 5 independent practices in Connecticut has become part of a bigger organization, which is sad, which is really sad. And one of the reason for that is that they said, well, you know, we give up. I'm very fortunate. I'm very fortunate because, one, I have partners who have the same vision. 2, I have folks in my practice who have a bigger vision than I do, that we should be treating patients in our own office, in our own community. And to that end, we have Christy, who's here, who gets assistance for patients. And I was asking her just now, you know, how much do you think we got last year for the patients? I want people to take a guess. Just take a guess. Co-pay assistance. How much do you think? You know, our chemotherapy drugs, pills are very expensive. How much do you think we would have gotten for patients? Throw a number out. Throw a number out. It's an auction. It's an auction. 200,000. Okay. Next. 1 million. Okay. Well, $1.1 million. You know, $1.1 million for patients in co-pay assistance. It's absolutely inconceivable that we are in the richest nation in the world, and our patients cannot afford medication. You know, we're in the richest nation in the world. Our patients can't afford electricity. They can't afford rides. We are arranging probably 36 to 40 rides for our patients in a given month. We are arranging rental assistance for our patients through our foundation, as well as electricity and everything else in between. We do fundraising for our patients' children for back to school. You know, we get them backpacks. But the reason is not for any other reason, but because we are a community. These are our patients. This is our community. Cancer care is local, and not just local, but it's personal. And our goal is to provide cancer care, personalized cancer care with a personal touch. It sounds cliche, but think about it. You know, you hear these ads about cancer centers out of Florida, even Yale or Hartford, saying they do this personalized medicine. Guess what? We have been doing personalized medicine for the last 7, 8, 9 years, even before they started it. We were sending our specimens out to University of Oregon for testing, even before they started it. We have been doing virtual tumor boards with all these leading national folks who give us these medications for clinical trials. And that's why I'm not making it up when I'm saying that we will be ready for phase 1, real phase 1 trials. We are doing phase 1B trials currently in our practice. And for phase 1, we need to remain open for a little longer time. But we will probably in the next year and a half, we'll get there as well. But it doesn't happen because we want to do it. It happens because our patients want it, our patients need it, and our patients don't want to travel far distances, and they should not have to. And so that's the reason why we feel so strongly about providing all this care for our patients in their own community. And I keep on coming back to the word community, 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 because that's where cancer care should be. This whole hoopla about this cannot be done here and this cannot be done, it is all utter nonsense. We should be able to provide very good cancer care in patients' own community with all the appropriate services that need to be there. Problem is, the system's limited, the state limits it, and everybody else in between wants to have a piece of the action about what cancer care really is. So we have to deal with all those roadblocks. Having said that, I have a staff which is very dedicated, who has the same vision as I do. I just say, hey, this needs to be done, and they do it. That makes it easy for me, by the way. So thank you. No, but jokes apart, I think I really believe in this, that we should be able to provide all the cutting edge cancer care services to our patients. So in our office, we have our own lab, we have our own dispensing, we have our own infusion center, healing touch, healing therapies. They come and give massages to our patients. We have pet therapy coming in. Our own patients make blankets, they make hats. One of our patients who's 80 some years, one of my patients who's 80 some years old, she's a native of Japan, and she's very much into origami. So she made like a 2,000 origami stuff.
Two of them.
It's very tough. She made a 2,000 bird origami. Really, I mean, and we had to open this up, and it really took care of our entire hallway, which was great. So I really think that all the systems and all the hoopla about cancer care, where we are going, we are really going in a great direction. And I sincerely believe it, that we are going in a great direction, because our testing tools are better, our diagnostic tools are better. We can now go down to a granular level on tissues. We can do genetics, we can do molecular testing. We are all doing that through our practice. We can get clinical trials in our practice open. Believe it or not, now this will be, does anybody know how long does it take to open a clinical trial at Yale or Hartford? Just take a guess.
Years.
Well, a good clinical trial, if it is sponsored by a company and the medication is good, it is NCI designated, it takes them almost 6 or 8 months to open a clinical trial just because of all the bureaucracy. How much time do you think it takes in my practice to open a clinical trial? Actually, you're absolutely right. We do what is known as just-in-time clinical trials. So if you have a patient and they have a mutation, we will be able to open up a clinical trial, not in 1 day, but in probably 3 to 5 days. Yeah, we open it 3 to 5 days, only because of regulatory issues, not because of our issues. So, funny story, when COVID started, we get a call from Dana-Farber, and the call was, hey, we have a patient who's got this mutation for lung cancer, and there's a clinical trial. It'll take us 4 months or 5 months to open the clinical trial. Can you guys see the patient? So we said, yeah, sure, we'll see the patient. We opened the trial in 5 days. The patient got on the clinical trial, and when Dana-Farber opened the clinical trial, we sent the patient back to them because the patient was from somewhere south of Boston. So people have a misconception that cancer care is only given in big centers. No, cancer care is given in patients' communities, but we need the entire community to understand what really community cancer care is, and how do we get together in getting physical therapy, social services, massage, healing, foundation support, and everything else that comes in between with those things. Without that, it becomes difficult and more difficult, because everybody, cancer patients, besides having the toxicity of their treatments, they have financial toxicity, they have emotional toxicity, they have mobility toxicity. And our goal at ECHO has been to really eliminate all the barriers that patients face and patients have. And I think we are there. You know, we might not be there completely, but we are there. And as Oliver Wendell Holmes said once, it's not about the destination, but it's about the journey. And we are on the right journey. And if we feel we are on the right journey and we believe in the right journey, nobody's going to stop us. And I really strongly believe that. So, you know, I mean, like I said, it's a very tough act to follow all the wonderful stuff that is happening in our own communities. But I would like to really end with this one little thing, that anytime somebody has a cancer or a blood disorder, they're not a number. They're a human being. They're a person. And my best interactions with my patients actually are knowing about them, making fun of them. They make fun of me. I love it. But I remember those things. They remember those things. And I think that's what we take pride in, knowing our patients at a very humanistic and a personal level. And we keep on doing that. We keep on striving to get better in doing so. So thank you very much. And keep doing what you're doing.
We've actually got a little bit of a surprise for you. Nyling, if you would please. It's just at the back. I'm going to stand away because otherwise I'm going to burst people's eardrums. And we've got a little presentation for you. If we can just have some hush for a moment.
So Dr. Kapur, we're so grateful that you were here tonight. We want you to know how much we appreciate you and your vision and your focus to provide independent, comprehensive, and personalized patient care in hematology and oncology treatment.
Thank you.
So we honor you and thank you so much, and we hope that many more systems and doctors will follow your lead.
Well, we'll make sure they do.